Bismillahirrahmanirrahim, and a very good afternoon to few of you who are still present after the lunch. And it's not because of my injury that I'm standing here, because I cannot talk while standing still. I have to move. Being a professor, I keep roaming from first row to the second, so I find it easier to talk while moving. So, as you heard, the topic of my talk is very comprehensive, but I was informed about it just a little late. It was my fault. So, I made the topic diastology, and I will try to do justice to the remaining parts. Now, since it's a very important, I believe in pathophysiology of the disease, because whatever and whenever you treat a disease, if you reverse the pathophysiology, the life becomes easy. So, we know that heart failure incidence is increasing very rapidly, and according to one estimate by WHO, in the next decade or two, more than 75% beds of any medical or cardiology units will be occupied by patients with heart failure. So that imposes a tremendous burden on society and makes us think that let's do something before a patient falls a victim to full-fledged heart failure. In order to do that, after myocardial infarction or whatever, you think that this left ventricle is now not functioning properly. So we need to prevent this progression of asymptomatic left ventricular dysfunction into systematic heart failure. Thank you, Dr. Tiku. Now, for LV dynamics, systole and diastole, both important since we are talking about diastolic dysfunction. I hope some juniors are sitting here, so I will take little role of Aage Dr. Tipu. Now for diastole, to understand diastolic function, you have to understand the basic hemodynamics between left atrium and left ventricle. And the peak filling rates that appear as E and A are determined by, number one, rate of myocardial relaxation, number two, left atrial pressure, then left ventricular pressure and compliance. One more thing, वो खौफनाक बेल ना देना, मेरा दिल के वो लगती है, मैं खुद ही देख के रुक जाऊंगी, चाहे मेरा आधे में ही हो. Please, that is horrible. Acha. So, you see, this is the basics. You must have seen this EA, everyone is talking about that. And how does it form? I see some juniors sitting here. You see, during ventricular relaxation, the left ventricular pressure falls below that of left atrial pressure. And flow is gradient dependent, so the blood gushes from left atrium into the left ventricle, and this forms the ascending limb of the E wave. Then there's a small interval where the pressures become equal, that is diastasis, and then the remaining part of the blood is propelled by contraction of left atrium, which forms A. So these terms are self-explanatory, E for early diastole and EA for A. Okay, next please, Dr. Tibus. So based on this basic pathophysiological mechanism, we grade diastolic dysfunction in 4 delayed relax. Next please, मैं बताती जाती हूँ. Okay, this is a very comprehensive slide. I think some of my colleagues, Dr. Tipu and Dr. Sohail, they've been to Mayo Clinic, and the 5-6 slides, I've just made them into one for simplicity. You can see the first one here, that is the normal pattern. E is twice the size of A, and of course, patient is asymptomatic, left ventricular size normal, and left ventricular and diastolic pressure normal. Now, when it gets reversal of E and A, mind you, this EA reversal is a feature of old age also. So when you, old age, maybe because left ventricle loses compliance, there is EA reversal. And I've often seen in a person of 80 or 85, the report comes grade 1 diastolic dysfunction, and they get perturbed and all that. You can label grade 1 only when the deceleration time of your E wave exceeds 240 milliseconds. So next one is very important. It is called pseudonormal. If you look carefully, it looks somewhat like normal, but the descending limb of E is very crisp. And then there is small a. And if you look at this left atrium, it is fairly big. Patient is severely symptomatic, and left ventricular and diastolic pressure is fairly high. But this pattern, it not only tells you about prognosis of disease, you can also predict the outcome. If at this stage of pseudonormal, you ask the patient to perform Valsalva's maneuver, if the left ventricle is still compliant, it will go back to this stage, and that means a good prognosis. The third one is restrictive. You can see very tall, sharp, crisp fall, and this is restrictive type. Left atrium is so big, sometimes it crosses your screen. Very patient is severely symptomatic with very high left ventricular and diastolic pressure, and this is the pulmonary vein tear. Next, Dr. Tibu, please. Okay, this is my study published. Next, please. Now you see, for those of you who do not have expertise in pulse Doppler, I always find this M mode tracing very useful. Look at this hump here, which is called, Japanese call it B hump. If you have this kind of hump here, this is more than 100% sure sign of raised left ventricular and diastolic pressure. Next, please. Next, please. As you saw, the things were good, this 4 stages, but the problem here was that they were affected by the loading conditions of the heart, as I told you in the beginning. And I remember I was at Mayo, and a young boy of 18 came, and he had this delayed relaxation. They all said, oh, he has grade 1 diastolic dysfunction. And a very senior eminent cardiologist from Denmark, she was very humble. She said, Dr. Tajik, why don't you take his detailed history? And that boy had severe gastroenteritis 48 hours before coming to me. He had collapsed suddenly. So they gave him a little bit of intravenous fluid, and the pattern came back to normal. Similarly, in hyperdynamic states, you may get a picture like that of pseudonormal, so you have to. So in order to exclude that, people then came to tissue Doppler imaging, where you can apply Doppler to myocardial tissue, and the running blood ka jo hai effect is taken. Next, please. So this was also good. Next. Here the problem was that this pattern was affected by movement of the chest. Since your heart is in the chest, आप बोलते हैं, लंबा सांस लेते हैं, ये हिल जाता है. And then people found another one. This is strain and strain rate imaging, because strain rate represents the Roker rate of myocardial deformation, and it's fairly reliable. Next, please. Now, next. Now, I was asked to talk about indeterminate diastolic dysfunction. And you see, these are the parameters, E oblique E dash, tricuspid regurgitation. Patient who did not meet 2 of these criteria were termed to be in indeterminate diastolic dysfunction. It is important because they have high rate of cardiovascular events, which means repeated admission and death, etc. Next, please. Now, and then diastolic dysfunction in atrial fibrillation. It's sensible to assume that here the parameters should be independent of atrial activity. And then you can see peak acceleration, isovolumic time is shortened, and deceleration time is little high, and septal E oblique E dash is greater than 11. So there was a question this morning when the lady from Bangladesh was giving a talk about number of beats. According to American and European Society of Echocardiography, they suggest that you should measure at least 10 beats, and then you can take that thing, average of that. Next, please. Now, why all of a sudden from diastolic dysfunction? This is a beautiful picture of my favorite country, Japan. You can see Mount Fuji at the back and beautiful cherry blossom trees. I'm a leisure-loving person and almost love diastolic dysfunction. And I was preparing, and then all of a sudden opened email, Dr. Shahbaz wants, you should include MAC also. Good heavens, now I had to climb Mount Fuji, but luckily it is a Japanese mountain and climbing was little easy. So I'll try to do just a little bit of this MAC. Next, please. Now, what is MAC? It is mitral annular calcification, and it is the deposition of calcium along the fibrous base of your mitral valve. And this reported incidence of 10%. Now, it has the same pathophysiology and the risk factors as those of your atherosclerosis. So that means that these patients are also at a high risk. And as we know that the reliable method of estimating left ventricular filling pressure in MAC would be of great value. Next, please. Now, we know that the 20th century, mostly in 2010, 20, last 2 decades, a lot has been published about diastology. So this era has been a decade of diastology. And now, we had better parameters, like we could measure E/E dash, that is the mitral E velocity with movement of the mitral annulus, and then it would have been easy. But it was noticed that in the setting of MAC, this was not a very reliable thing. And surprisingly, the classical E/A velocity correlated better with cases of MAC than E/E dash. Thank you. Next, please. Then the problem here was that since the base is calcified, your blood will run through a narrowed area. Area annulus ka narrow ho jayega, and also because of thickness, mitral annular velocity kam ho jayegi. So you will see a pattern somewhat like pseudonormal. So then they said, okay, we need to do something else. But they noticed that mild cases of MAC correlated fairly well with AE. Then there was a study. I normally don't do that. There's a study in JAC in 2017, and this person, Abu Dhabi, they performed these 50 patients, and they also did concomitant right and left heart catheterization, and they found good correlation of EA with mild cases. And they said that, in patients with, EA worked well in mild cases and severe cases. But the problem was those of intermediate or moderate cases. Next, please. Next. This is a picture. They've shown a 71-year-old female. Here you can see calcification. And second, she has an intermediate EA of 0.85 and I/T of 135 milliseconds. It indicates normal LVP according to proposed. And then tissue Doppler imaging of infroseptal and anterolateral mitral annulus reveals an average of greater than 14, which would have suggested elevated left ventricular filling pressure. But again, it is rather uneven. Echocardiography, next please, is good, but it cannot differentiate between calcification and dense collagen. Next, please. Next, Dr. Tipu. Then next, Dr. Tipu, CT was then CT again, spatial resolution. Time is up. Then isovolumic relaxation. This correlates well. Jitna chota isovolumic relaxation hoga, pressure is high. So patient with EA below 1.8 were classified was having normal, and above that elevated. So this study states that isovolumic relaxation phase can be useful in predicting cases with immediate. Echo is limited by its inability to distinguish. Next, please. Here, CT ke saath spatial resolution. So in the field of diastology, we still have to learn a lot. So don't be so quick to throw out MAC. And here I am. Thank you.
Thank you very much, Dr. Nusrat. Excellent talk. Any question? So if there are no questions, Dr. Shahbaz.
Excellent talk by Dr. Nusrat, and these are the areas which we suggested her to talk, because she's an expert in diastology. So that is where people are generally stuck. So she has very nicely explained the things. And do you think, Dr. Nusrat, the diastolic stress test, as Dr. UP Singh was saying, would be helpful in difficult situations?
The mic is.
Yeah, it should be, but to tell you the truth, since I'm not doing it myself, I'm very, very uncomfortable to talk about something that I don't have my personal experience with. Of course, now this thing is coming up. We learn more, and maybe for next meeting, we can talk about it and I can give you my personal experience. Thank
Sure.
you.
Thank you very much, Dr.
Thank you.
Just a comment on this. I think it was a great talk by Dr. Nusrat. And I think I learned something nice and new, like the statement. I always write down mitral valve annular calcification. I can call it MAC from now on. And the fact that TDI is not as helpful in that as because we routinely do TDI for all our patients. So that's a very good point. And the paper from 2017 seems to be an interesting one worth reading. And my laptop.
I just have a small comment, a very nice review by Professor Nusrat. But I think when you examine patients with heart failure, or you suspect heart failure and you refer them to the echocardiographer, most of the times, the echocardiographer has difficulty because the referring people, they forget to mention any clinical, significance or the background why they want an echo on the function, especially if the systolic function is normal and there is heart failure due to diastolic dysfunction. So I would definitely recommend everybody to write the clinical findings which would help in making or excluding a diagnosis of diastolic dysfunction, and especially the rhythm of the heart plays an important role in the diagnosis of diastolic dysfunction. So I think everybody should have at least an ECG and a note of clinical findings, and don't expect the echocardiographer to do your homework for you. Thank you.
Thank you, Dr. Nadeem. But in my case, the advantage, I am the echocardiographer and I'm the examining physician. So I always, sometimes ladies come and they say, "Ji, falan doctor sahab ne kameez upar karke kar diya." I've made special gowns, पूरा वो करके, history लेके, echo से उन stethoscope से सुन के, then an ECG, and so this is added advantage of doing it yourself. Thank you so much.
Yes, I think it's very important to have the indication for any test, especially for echo and imaging studies. Ji, Dr. Sahab.
So I have a question. As far as guidelines for diastology are concerned, there are the 4 parameters which we have to see. But the textbook says there are many other parameters as well, like velocity of propagation and E over VP, and there is with ECG timing and also on M mode. I'd like comment from ma'am, how important are those, and are those really needed in some cases, or these are just an addition to these 4 things?
Description and practical. When you are doing an echo, it may not be feasible to do all that, although it should be ideal. And since I was only 15 minutes, and just to tell you, I was badly injured in an accident just 10 days ago with so many painkillers and all that. I was in a very bad state. So I kept praying to God, give me the strength to say a few sensible words. Yes, these things are important. I did read all those, but it may not be possible to describe nitty-gritty here in 15 minutes talk.